Hello everyone, welcome back to my channel. Today I would like to discuss with you guys a very common entity and actually has very interesting and classic imaging features that we all need to get familiar with. If you're a general radiologist, it's a must know for you guys, and if you're no radiologist, definitely it's just your day-to-day working case that you're just going to encounter. And if you're a patient, these are important imaging features and verbiage that is just going to be in your reports and you can just get familiar with and learn what these things are meaning. Basically, this entity, which is basically the melting process or the hallmark is multiple sclerosis in adult, happens usually in female or women that they are in their 30s or 40s and they just come with weakness, numbness, some sort of visual disturbance or like visual problems. And in this patient is specifically presented with headache, very non-specific. And I think sometimes you are the first person or radiologist is the first person to make the diagnosis or actually suggesting the diagnosis, because this is not an imaging diagnosis, it's usually clinical, but uh, like we have some imaging features that they are supporting or they are just like highly suspicious or basically they are concerning for the melting process. Okay, let's dive in. This is the regular brain MRI with routine sequences. This is a sagittal T1 sequence. As you see, this the fat in the subcutaneous tissues is just T1 bright, and that's how I know this is a T1 sequence. The CSF inside you see is all dark. That's another sign that this is a T1 sequence. Okay, when I scroll through, I start seeing some lesions. Let's keep going. I just show you the other side. So you see these lesions that they are oval shape and they are perpendicular to the ventricles. And then if you go down, you see again more oval shaped lesions. So these are called Dawson fingers. So basically these are multiple sclerotic lesions or demyelinating lesions that they are perpendicular or like fingers going towards the ventricles. That's why they are calling Dawson fingers. Very characteristic imaging features for multiple sclerosis. Okay, let's look at these DWI sequence. This is a DWI sequence, and actually it's interesting because I just encountered with some of my residents. They were asking how you just differentiate DWI from other sequence. Maybe it's just for a more junior reason. It's difficult to differentiate DWI from other sequences. But this is just, if you look at them, the outside soft tissues is just not very well seen. Mostly you see actually the brain parenchyma, and it's just not a very clear sequence as you see. So like basically outside not very well recognized. So that's how you know this is the DWI sequence. So when you look at this, we are looking for restricted diffusion. So I see the lesions are bright. Those lesions that I showed you on sagittal T1, actually some of them are bright. But if you look at the ADC, we cannot interpret DWI without ADC map. When you look at the ADC map, we see that most of these lesions actually they are bright on ADC. That means this is T2 shine through. It's not real restricted diffusion, and these lesions are chronic. There is no active process happening at this point because these happened in the past, and now they are not showing restricted diffusion. Okay, this is a GRE sequence, and basically one important finding that is not going to show on this one because we need more sensitive sequence like SWI or so on. But on SWI or so on, you can see central vein sign. This is another imaging characteristics about multiple sclerosis or demyelinating lesion. But this is just GRE; it doesn't have that sensitivity to show that. Okay, so now we have the hallmark or the money sequence is going to be either T2 or FLAIR, and you see this is a T2 sequence. All those round lesions or oval lesions that I showed you, they are perpendicular to ventricles. That classic imaging feature that you see for multiple sclerosis, very classic. And they are in juxtacortical or preventricular distribution. As you see, this is a juxtacortical lesion. These are preventricular lesion, and this is very classic feature for multiple sclerosis. And then we need to talk about the distribution. So those lesions mostly, as you see, these are preventricular and juxtacortical. But if I go down, I don't see any lesions in actually brainstem that much or in the cerebellum. So these are pertinent negative that we have to put in our report. And actually, I don't see that much involvement on the corpus callosum as well. So that's the T2 sequence, and then I just similarly we have FLAIR sequence. It's just going to show better those stuff that is show you. These are the lesions that we are going to see. Let me highlight it a little bit. You guys see, so these lesions, as you see, these oval shaped lesions, these are probably the melting plaques. And as I said, we don't see any lesions in the brainstem or cerebellum. And then lastly, we just want to look at the post-contrast sequence. This is a post-contrast T1 sequence, and the reason I know, because you see the vessels are all bright, so you see the superior sagittal sinus, you see the arterial structure, so this is basically a T1 post-contrast sequence. And usually post-contrast always done on T1, that's how you know it. Okay, so when you just look closely again, you see that these lesions, they don't have basically enhancement. And actually, although the central vein sign is not happening on the postcard, but you see that there are some central veins here on these lesions as well. Okay, so it shows that these lesions are not contrast enhancing. So this is another feature that these lesions are not active, and it happened in the past. So very classic imaging features for multiple sclerosis. They are oval shaped. In distribution, we have to talk about juxtacortical or preventricular, and also we have to talk about brainstem involvement, corpus callosum involvement, cerebellar involvement, and then we have to talk about these lesions if they are restricting or enhancing, and if they have corresponding T1 hypointensity, which is a prognostic factors, because if these have corresponding T1 hypointensity like this one, as you see here, it has just a little bit worse prognosis, and shows that this like disease is going to be more on the side that doesn't have a good prognosis and keep progressing. And then the other thing, then we have to talk about volume. So this patient is just about a 40-year-old, and the volume is not that bad so far, but multiple sclerosis causes volume loss over time. But you see the corpus callosum is not that bad, and actually these ventricles, they are not that bad size, so it's at this point doesn't have volume loss. So just get familiar, because in radiology, one of the things that I just realized over some years that I'm practicing, it's very important to always think out of the box. Just don't look at the like what diagnosis the patient sent to you. It's very important to use your knowledge, use the thing that you are seeing in the imaging, and just find other explanation for the patient's symptoms. So this patient came to you, so for instance came to me for headache, but I don't see anything that like explains the headache. So this is not imaging features for migraine headache. You might see some lesions in the frontal lobe, in the subcortical distribution, very few, like maybe 1 or 2 in a patient at their 40. You're not going to see these extensive abnormal white matter lesions. And when you see these features, you should flag and just basically alert the clinician or referring physician, which is sometimes it might be just a primary care physician, that this is not something that you are going to see in headache. This is something beyond. It can be multiple sclerosis. There are also other differentials here. It can be like other prior infectious inflammatory process. It can be like toxic metabolic causes. It can be like vasculitis, all other stuff. But it's really important. Always think out of the box. As a radiologist, try to just put your clinical information, imaging features, and come up with a good diagnosis that fit everything. Okay, hope you guys enjoyed this session. I personally really like that. I mean, this is the time that you guys as radiologists can just add value, because you just provide something that nobody thought about it, and then you can just send this patient for neurology referral and just get appropriate care, unless this patient keep coming and just complaining about headache, which is not actually the reason for all these symptoms that they might have like for many years. Okay, thanks for listening to this session, and I hope you guys enjoyed. If you like this video, please don't forget to subscribe and follow me on this journey. Again, you're going to see more interesting cases along the way. Thank you.